Hey, save the best for last, always. Good job. Okay. Well, today we're going to be going through atypical Nevi. Last week we talked about all of the Nevi that are benign and are not at of a risk of developing into something that is melanoma, but the atypical, aka dysplastic nevus, it does have that risk factor to where it can advance and get into some of the melanoma. So we're going to talk about that. We're then going to break down all four of the actual melanomas that are out there. So again, just like always with everything in of medicine, there are different aspects that are related specifically to certain disorders, diseases, those things like that. So we will highlight some of the differences between those four of the melanomas that are specific to what you would think that it is. All right, so first let's talk about the dysplastic, aka atypical nevus, right? So we know that this is one of those things that can be occurring in 5% of the Caucasian population, okay? Starts off in some of the puberty, right? So you can have some of the parents bringing that child in, having to take a look at it, right? It's going to grow, it's going to change, and again, those are all of those ABCDEs that we are going to go over and over that are there for us to recognize these things, okay? Equal incidence in both of the sexes, so it's not just male or female, it can be either one of those, okay? Morphological wise, we see that this is usually greater than 5 millimeters. This is why it's part of the differential diagnosis for a melanoma, because we're going to talk about the melanomas that are all over greater than 5 millimeters. So this is one of the reasons why we do this, okay? These dysplastic nevus, it can be flat or it can have some of that raised. So it's described as of a fried egg. So you see that sitting there. Again, there's a lot of pictures in this slide deck, so we're going to be seeing those there. ABCDEs, that's those things that we're going to talk about over and over, okay? These things are often, if we're looking at the color, they can be darkly or irregular pigmented. So it's not all just one of a color. You can have several of those colors. Irregular or indistinct borders are some of these things. Again, differential diagnosis, because these are going to be some of those same things that we're discussing once we get into those 4 melanoma abnormalities. Distribution wise, not only because it can be in those sun exposed areas in like, the back of the upper lower limbs, but it can also be in of the sun protected areas, right? So breast, scalp, buttocks, groin. Diagnosis wise, we need to be able to see 3 of these ABCDE things, right? So we've got a diameter that's greater than 5 millimeters, that ill-defined borders. If those are of the borders, it's hard to see where it starts and where it stops. It looks like it fades away, or it's just not distincting. Irregular margins, varying the pigmentation, or last, they can have some of the papular or macular components, okay? On the slide deck, there's this chart right here that breaks it down with all on the right side of the chart was all of the benign stuff that we discussed last week. But on that left column, that is what is dysplastic, what is atypical of the mole. So it just breaks it down. Treatment-wise of the dysplastic nevus, right? Excisional biopsy. Again, we are going to refer these individuals on. If we're seeing A, B, C, D, E's and we think that they've got 3 of the 5 letters, that we are going to refer them, especially so that subject matter expert will perform the adequate excisional biopsy. Once we are doing that and we have some of that excisional, those of the dermatologists are going to have them take some of the pictures, how it looks, so that they can continue to have some of the follow-ups with them to repeat of the skin examination to compare it if there's any evolution that is happening that could have that, okay? Of course, we always want to educate. We want to teach A, B, C, D, E's so that they know those things, okay? We also need to let them know, hey, you have dysplastic nevus, so you might want to let your brothers and your sisters and your children know some of that same stuff. If they're having this and it's located in that trigeminal area, of course, we will want to consider some of that ophthalmologic exams, okay? So refer them on so that they can be looked inside of the eyes. So dysplastic nevus, atypical. We can see you can have, a few of them, or you can have an entire back, right? So just like when we were talking about benign stuff, we talked about SKs, AKs, we talked about all of these other things that it could fit into that category to make you want to rule it out. You can see that big guy, that ugly duckling, right? That's there and it's jumping out, but the other things could be dysplastic nevus as well. They're just looking differently. Again, all of the colors are not the same. They are different. The border, you can kind of see how it, ends, but it's still light skin in that area. So does that border extend beyond what it is that we're actually seeing? We don't know. Again, border, different colors, very different colors. That fried egg sitting up on top of that macule. Again, so that is all of the dysplastic nevus. So these atypical things that are in of the differential diagnosis that we're going to pursue and to evaluate, look it up so that we can make sure that it's not going to jump. All right, so that was part 1. Part 2, now we're getting into the melanomas. So we're going to describe some of these first, and then we'll get breaking them down into different of the categories. So, epidemiology-wise, malignant melanoma is the 5th most common cancer in men, and it's the 6th one in women. We can see some of that age, right? So 57 years old is sometimes when an individual is finally seen and they've had some of referral for a dermatology for excisional biopsy. Median age of death, 67. Talked about of those males that are higher risk than of the females because it's 5th most common in men, 6th in women. And we know that with all of our skin cancers, specifically talking here malignant melanoma, Caucasians are 10 times greater risk than Black, Asians, Hispanics. So that's of the higher risk that is there. This right here is a beautiful chart because it's spelling out the relative risk, right? So there we can see if that individual has a personal history of atypical moles, family history of melanoma, and greater than 75 to 100 moles, that is a risk of 35%. And then it has that chart continues on. Modestly increased risk, again, sunburn wise, if they've had it 3 times, 3.8 to 1.7, and it just goes on to different aspects associated with that individual that increase the risk of them developing malignant melanoma. Not only do these charts calculate that, you remember the next chart that's all about the skin phototype, right? 1 and 2 are at a greater risk than 6 and 7, right? Down at the bottom. So we've got that skin phototypes. Not only is their color of their skin have manifestation, it can also be their UV exposures. Okay, so what is their job? What is their recreational sun exposure? Yeah. So what could be making that of a higher risk? There's those phototypes that y'all are all experts on. So 1 and 2, great risk. 5 and 6 at the bottom, not as likely. So what does ABCDE stand for? Asymmetry. So it's not symmetrical. It's not balanced. There's not a perfect circle. Okay? There's something that is just not the same. Border irregularity. Okay? So we can't see where it starts, where it stops, where it's, at. The color variation, right? Light brown, dark brown, black, blue, there's just all of those different things. Diameter greater than 5 millimeters, enlargement, and that evolution is that change. If they took a picture of it a year ago and now it looks way differently, well then what the hell is it doing? What is it expanding? Anywhere, we can have these things anywhere. Not only is it on of those sun-exposed sites, but we can see these things on of extremities, so of the sun-blocked ones. You can see how we are listing on here, how there can be developed into a malignant melanoma that is non-cutaneous, so mucosal. So it can be on of gingiva, it can be on of the cheeks. These things can spread, okay, metastasize, they can, develop. So mouth, nose, eyes, penis, vagina, anus. Those are some of those locations that this malignant melanoma can occur. Looked at this chart several times last week. So that's, again, the ABCDE, right? So we can see all of the things that are on of the right column. Asymmetry, border, where is it at? Difference of the colors, diameter greater than 5 millimeters, and evolving. What is it developing? Spoken earlier. That ugly duckling, one is different than the other ones. So what is its component? What is it being? Again, pointing the ugly ducklings out. So there we go. What is this? Dermalite, so this is that dermoscope. So basically it's a micro that is held in your hand and you can look up and underneath of it and visualize that what it looks like, right? So raised, variation in of the pigment or of the borders, alteration of skin, lookalikes, okay? So that's something that you will all get to see, use once y'all get into phase 2 and you're in one of the derm rotations. You will get to see these things. So, being what you are all going to be when you grow up, primary care management, okay? These are the aspects that are going to be what you will want to do, what you will want to act, okay? So of course, we're always going to get of the HPI, we're always going to get that history, asking specifically about A, B, C, D, E's, there. We're going to ask, does it hurt? Does it itch? Does it bleed? Is it oozing, crusting, ulceration, erosion? Like, what is it acting like that would make us need to rule it out? We also want to know of their personal history, sunburns. Have you used some of the SPF? What is your job? Are you under some of the sun-exposed area? Are you on any of medications that have risk factors because of the photosensitizer? So are you taking something for a condition that is requiring or that could be having that, okay? Have you had skin of the cancer? Family, We're gonna want, to check if they're having some of the fevers and the chills, night sweats, weight loss. We're gonna be getting some of those labs, right? So that we can see if they're having some systemic manifestations, if it's metatizing, if it's doing those things, okay? Let's give them a grade. Let's say you're a 1 or you're a 2 or you're a 6, who knows? We're going to be doing total is the key word, body sun exposure examination, right? So we're not just going to look at that ugly duckling. We're going to have to go to them from head to toe, looking at everything, including, as you see on here, it talks about the palms, talks about the soles. We're going to get into acral melanoma, and that happens in those areas. And so that can be one of those things for us to look into, okay? So yes, we want to look there. Lab-wise, those are the 3 common labs that we're looking for leukocytosis, if we're looking for metastasis, right? So CBC, CMP, UA, those are labs that we will be doing if we're trying to rule in or out malignant melanoma. The other thing we're doing is we're going to send them to the specialist, right? We're not going to be the one to do that excision. We're definitely not going to be doing any of the shave biopsy, because if it is believed to be melanoma, you got to cut everything out and not just punch at it. We're going to excise beyond all of that borders, not only what we can see from the skin, but also for the depth. So how deep is it all the way down through of the dermis, okay? So refer to derm. Of course, we're gonna say A, B, C, D, E's, like always. Follow up every 3 to 4 months for 1 year, then every 6 months thereafter, if it is a malignant melanoma. Regardless of which type of a melanoma is, if it is that word, melanoma, then that is what the follow-ups with derm will be. Make sure they're going. Get your ass over there. Prognosis. Okay. The prognosis is directly related to the tumor size, aka the depth. So epidermis, dermis, is it sub-Q? Or like how far is that Breslow that would say what that a prognosis is. If there is, from the labs and other examinations that you're doing, if they're having some of metastasis, then that prognosis is grim, because that could be worse. As you can see there, median survival of 6 months. So if it starts to spread, then no bueno. We've got Breslow and we have Clark. Breslow is of the most important aspect. That is a microscopic depth reported in millimeters. Okay? How far into the skin is it going? Clark level, yes, that is, something that is of a dermatology expertise, but that is reported by the anatomic site. So if it's epidermis, then that's a grade of 1. If it's all the way down into of the sub-Q fat, then that could be a 5, and vice versa. So that's the prognosis. Showing you a chart of that Breslow depth. It puts that percentage year survival. So 5-year survival. If it's less than 1 millimeter, then that's pretty damn good. Okay, 95 up to 100% survival. But if it's all the way down in the sub-Q part, so it's, greater than 4 millimeters, that's a 50-50. You got a chance. Okay, 50-50. Okay, so that was all just speaking in general to malignant melanoma. Now we'll break it down into the 4 types that are out there. Superficial spreading, most common, as you can see, by 70%. Nodular, lentigo maligna, and acral lentigious. So these are the 4. Again, they'll have specific key components. So, superficial spreading melanoma, SSM, most common type of melanoma, because we're seeing that in 70%. This can happen at any age. Most common, 30s to 40s. Can happen anywhere. Most common is located on that upper back, as we saw in some of those ugly duckling pictures. Of course, it's not symmetrical, so it's irregular. The borders, hard to see. Begins as a flat or elevated brown lesion, and the hallmark is haphazard combo of many colors. So it's not just one color, you've got several different the color types. If it's growing, if it's getting big, if it gets over 2.5 centimeters, then it's going to develop into some of a nodule at that time. So that's there. Again, breaking down the ABCDEs, we see asymmetry, irregular border, brown to black macule initially, but it can develop, okay? Diameter is typically greater than 5 millimeters, and it undergoes radial growth first. So this one does go through some radial growth. Evolves into black, blue, white, red, and undergoes vertical growth elevated. So it starts off with that radial growth, but as it's evolving, then you get some of that vertical growth. And vertical is which one? That's that Breslow, right? So how vertical does it move through those epidermis, dermis, sub-Q? Chart that's just, again, showing that up. Initial phase, radial growth phase, months to 10 years, months to years, then it gets into that vertical growth. So that's a part of that superficial spreading. You see that bottom picture there? Shows that blue, gray, blue, black, red, and white. It's just all of those colors. Photo-wise, that's not just one color, right? There's several different colors. Asymmetry, border is not good. Diameter greater than 5 millimeters. And it could be looking different than it did before. Pictures, pictures, pictures. So superficial spreading melanoma, that is the most common. That was 70%, oftentimes seen on of the upper back, but it can be those other locations. Talked about that it started with what phase? Radial phase. Nodular, no radial growth. This is all vertical. So nodular melanoma, 15 to 20%. It can occur anywhere. This age is set around 40s to 60s. Most common dark brown, red black. Again, differential diagnosis of a nodular melanoma. They can be what we talked about, that SK, dermatofibroma, blood blister, hemangioma, dermal nevus, so some of those benign things that we talked about, okay? Again, nodular, no radial growth. Dome-shaped, polypoid, pedunculated, so it can be, out because of the papule, because of a nodule. Border is irregular, brown to black, rapid size growth, evolves with that ulceration, with the bleeding, so that's there. Just like that superficial picture had that radial growth phase on it, then this one does not. This is all vertical growth. We can see how we've got that plaque, dome shape, polypoid, and it's just breaking it down. There's the nodule sitting on top of that plaque. You have some of that red, some of that purple, some of that black. This individual has a beautiful mouth. Pedunculated. That's all coming out of that back of the leg. Okay, dark. So that's the nodular one. Up next, let it go. Okay, malignant melanoma. The reason why I say that, let it go, is because this is a slow one. This is mostly older people, so they let it go for many years. Okay, so it's older, 60s up until 70s. It takes slow growth, so it develops in and of its time. Face is the most common, but you can also have this on that neck and arms. Shows up as that brown to black macular pigmentation, raised blue-black nodules. 5% risk of becoming invasive. So of course we can have some of metastasis. But lentigo, malignant, melanoma, slow growth. Again, this one does have radial growth, 5 to 50 years, vertical growth, years. And you can see how that black spot there develops slowly, right? Once they get old, then they can have that as seen on of an ear. Below the eye. Again, refer them. Okay. So those are the first three. The last one, acral lentiginous. Okay? Most common form in darkly pigmented people. So DPP. So if we're giving them of a skin of a phototype, then it could be down at the bottom of that chart of a category of 5 or 6. Okay, so African Americans, this could be Hispanics, this can be, Asians. These are those things that are specifically most common form of that darkly pigmented people. You can see how it rates that at 30 to 75% with of the DPP, but the LPP, that's only 2 to 8% have that. So acral lentiginous, let's think dark skin. Not only is this more common with darker skin colored individual, but this one, acral, this can be seen on the palms and the soles and the fingers. Mucous membranes also. So this is not on the upper back or sun exposed areas. These are hidden. Okay? Why we talked earlier that you as a primary care manager, if you're looking at one of an ugly duckling and you're going to do of a total body skin examination, you're gonna also look on the bottom of the feet, to the hands, to the scalp. We're gonna look at those places. So acral lentiginous is that. The other thing is that when we were in block 2 and we went through all of the nail stuff, y'all were taught about Hutchinson's sign. Hutchinson's sign is that vertical darkness of a finger. So sudden appearance, pigmented band originating at the proximal nail fold. Okay, so Hutchinson, palms, soles, dark colored people. And if they are having some of the acral lentiginous melanoma, you'll see some of the pictures. Their prognosis is not good because by the time it's there, it's already, So, again, dark colored skin, the sole. So that's on the bottom of the foot. There's Hutchinson's sign. That ankle area, that's probably been there for a while. Again, that's why the prognosis is not good to go. Nails, again, So those are the 4 types of melanoma. Overall, these are some stats, I guess you could say, statistics that are talking about of the skin of the color type, okay? early stages of malignant melanoma are diagnosed less often in DPP. So of the darker the colored skin, oftentimes they're not seeing one of these lesions. So they're not diagnosed as often. Stage 1, 39% are seen in the dark skin versus 60% of the other ones that are easily seen. Survival rates decline with delay in diagnosis. Okay, so survival rates, yeah, you're gonna go bye-bye. 90% of malignant melanoma in light skin are seen. 67% are not on of the sun-exposed sites. Okay, so 90% of Caucasians will have something seen, diagnosed, and treated, whereas 67% of darkly skin-colored people are not on sun-exposed, so they're not seen, like they're on the bottom of the foot or they're somewhere else, which is exactly what it says there. 40% are on the foot, 2% are on the foot. Not only can you have those areas, but you can also have these melanomas with of the dark skin colored people, subungual, mucosa, plantar, palmar. So it's those non-sun exposed areas, the spots that people won't look at. Talked about that, of course. Total body skin examination. We will include the palms, the soles, those areas, because of that high index of suspicion, and we want to rule that out. Specifically, breaking it up, this is a little bit of some changes that are specifically for of those African Americans, Hispanics, Asians, age, okay, that can have that happen in of the 5th and 6th there. Brown or black band, change, digit, okay, they get these things on their fingers, like we saw with the Hutchinsons and all of those pictures. Family history, okay, so breaks it down. Now, this figure basically just is all about block 3, right? So it starts with the stages, right? So it's looking at benign nevus, dysplastic, talking about the radial growth, vertical growth, and metastastic, right? That's where it's all the way on the far right, and that is having a prognosis that is no bueno. Okay, so it's just breaking that down, and again, it's the depth of it. How far down the skin does this go? We know that right smack in the middle is that radial, right? Because it's got a better prognosis. If it gets into vertical, so it's getting deeper, then that is not a good prognosis. Basically stated here, horizontal radial growth phase has a better prognosis. Once that gets into that vertical aspect and it's diving down deep, then the prognosis worsens. They could be having some of that metastatic development. Again, there. So it's no bueno. Breslow, most important histologic determinant of the prognosis. How deep does it go? How deep does it dive? Okay, reported as a Breslow level number what? Of millimeters. We talked about that it's around that over 5. That's when we know, not good. lymph node involvement, right? If we're having some of that metastatic, then lymph nodopathy can be occurring, and that would be, determination of the prognosis. Another of those pictures. As you can see, that figure that is on that far left shows you where that lesion is at, but you can see how all of excision is up and underneath. That's why if we believe that this is some type of a melanoma, refer to derm, because derm is going to excise it, not of a shave biopsy, not of a punch biopsy. They're going to get in there and excise it all out, because on the picture you can see how it shows that lesion that's right here. So it's here, and they cut further down below. So it's over here too. So there's the melanoma right there. So that's why refer. Again, melanoma, major independent prognostic factors, whatever. Final thoughts. Approximately 80% of melanomas arise on areas normally covered by clothing, okay? So it's not sun-exposed areas. It could be on the upper back that has a shirt. It could be down on the palms of the soles. It can be on those fingers. Consider TBSE on all patients at risk and at all routine physicals. You, primary care provider, has the greatest opportunity to catch an early melanoma and make a timely referral to dermatology, so make me proud. Okay, so that is talked about dysplastic, broke down into superficial, nodular, litigo, and acral breakdown. Do we have any questions? Okay, tomorrow I'm here with y'all at 1, and tomorrow it was going to be starting into some of that rheumatological stuff, okay? So we're going to go through those things tomorrow and on Friday, and then that will be the end until we do a test review on Monday morning. Okay, I'll see y'all tomorrow.